Hello and welcome to Healthcare Rewired, the podcast that explores actionable lessons and insights for improving healthcare from digital health's leading innovators and champions. I'm your host, Mark Noble, and I'm honored to be discussing strategies and techniques for executing on rural health transformation plans in a manner that both complies with CMS requirements and establishes truly impactful rural health programs with Christian Milaster, founder and CEO of Ingenium Digital Health Advisors. Christian and his team have been focused on transforming rural healthcare since 2010, with over 120 objective design and implementation engagements in more than 25 states. He's published over 330 articles on rural health transformation and is a frequent speaker at industry events and podcasts. Christian, welcome to the show.
Thank you so much, Mark, for having me. Really excited to be here and looking forward to diving deeper into how healthcare organizations and leaders can prepare for this really great opportunity of investment into rural health.
Likewise, my friend. Let me set up the challenge for today's conversation. So we know that all 50 states went ahead and applied for $200 million for year one funding. And of course, none of them got exactly $200 million. So everybody right now is going through a budget justification or adjustment period to go ahead and get lined up with what was actually awarded. And then follow that on with a up to 45-day period for CMS to review those reconciled budgets and approve them, so on and so forth. And we are now looking at somewhere between, sometime in February to mid-March that the states will start putting out their own requests for applications and requests for proposals and that sort of thing. All that to say that CMS has put out guidance that said you have to be able to demonstrate progress by the end of September of this year, which is the end of year one. It's aligned with the fiscal year for the federal government, which obviously doesn't leave a whole lot of time to find your partners, award for specific projects, get them up and running, and be able to capture that data. So Christian, starting from that perspective, what advice would you give to the CEOs of rural hospitals and clinics that are looking to apply for some of this funding through their states, understanding the dynamic of having to demonstrate outcomes with the idea in mind ultimately of putting together really impactful programs that will make a difference in the long haul?
Yeah, very good question. I'm sure that's on some people's minds. And CMS has definitely changed its approach in this type of a NOFO than in other and prior years. And I welcome that. I welcome the accountability. I welcome that it doesn't, that the money just doesn't get just spent on buying stuff and then it sits on shelves endlessly. And so I really want it to drive outcomes. I think there's my first guidance would be, and that's probably tied to my personality, is like, don't worry about it. It's the funding is for 2 years. The funding is technically for 21 months, or now that we're already 1 month in or 2 months in, right? It is for 19 months, meaning there's a fiscal year that is ending in September 30th this year, and that's a first kind of reporting period. But then there's another 12 months available to actually leverage that money, that first funding period money, to use it. In October, we're going to get another influx of 200 million plus or minus 60 or 80 million. And that's going to be for then the following 23 months, because CMS always wants to kind of wrap up and get the reports out by September 30th, and they will take September actually to review the progress. So and then they will refund it. So the first guidance to CEOs: don't worry about your September 30th, 2026 deadline, except if in the RFPs or the RFAs, the request for proposal or applications that are being issued, there are specific expectations with regards to what you need to show for. Because it's really not, right, the CEOs are not going to be held directly to the CMS standards. It's through the interpretation and the structuring of the states that are going to putting out these RFPs. again, Congress passed the bill that authorized this funding in June of 2025. They knew they couldn't kick it off in October, which would have been the beginning of the financial year. And so this is why we in this first year we're behind. And I'm very sure that pragmatically speaking, CMS is not going to expect anybody to show meaningful outcomes within 3 months or 4 months, as you pointed out. If funding goes out, if funding reaches the healthcare organizations in April, you have April, May, and June to implement something, and in July they come start knocking and looking at what you've done with us. So obviously there's limited that we can do, but it's really setting the stage now. What outcomes are you going to create in September, by September 2027 or by August 2027? That is the real question, and we can dive deeper into that, how you design actually your activities within your organization to prepare for that.
Yeah, and those are great points, Christian, and I agree with you. There'll have to be some adjustment of expectations, right? I know that some of the states that got started earlier were designing with the intention of having clinical outcomes to show by the end of July of this year. So, for example, when the state of New Jersey dropped their RFP or RFAs, I should say, at the beginning of the year and had a turnaround by January 20th, that was with the intent of having some clinical outcome to show in that initial performance period. But I've heard other states since talk about demonstrating the build out of infrastructure as being the progress to be shown. So I hear you loud and clear that there'll be some interpretation around that. Given the variability in the rural health transformation plans from state to state, as these individual health systems and hospitals and such within these states go to think about how to position the programs that they think will have most impact in their community, talk to me a little bit about how you would advise them to go about positioning and setting expectations around those programs in their applications when the request for applications get dropped.
Yeah, this is the time to activate the leaders on your team that have a high tolerance for ambiguity, because right now there's just not much specificity. Yes, you can look at the application, you can look at the activities that are there, but still it's up to the state to decide what are they going to put onto the plate in year one, right?
Yes.
The 6 weeks time that the states had to put together a proposal was for a 6-year program, right? 5 funding periods, but a total of 6 years. And so it's a huge buffet across the very thoughtfully selected goals that CMS put forward. But now you're at the mercy as to whatever the state decides it wants to do. Now they tried, but they had an input period last year in August. Most states had, and some people suggested ideas that they made in the applications. But now they still need to prioritize what we're going to focus on in year one, year two. And so I would just proactively go out into the application, into the activities catalog. All the states have basically identified between 4 and 15 initiatives, and then each initiative is broken down into multiple activities. And just take a look at the things that you are already well positioned for to leverage an influx of funding to make a big impact that will help your state to look good when CMS comes knocking and wants the outcomes data. So what is it? Is it, have you done like a pilot with RPM, but you want to really roll it out bigger, or you start with hypertension, now you want to go to diabetes? What is it? Is there something that, do you have an EMS service in your health system that you run? Do you want to expand on that to establish treatment in place scenarios? Are you in a maternal health desert because your local hospital's maternity ward was closed? Right? Can you now fill the gap if you're an FQHC or smaller rural health clinics? Can you fill the gap? So just look at what is in your DNA. Look at your strategic plan that you've developed this year or last year, and see what are the things that you want to do, and ask somebody on your team to just overlay that. Which activities align with your existing DNA. And I would also suggest to make some investment in some advisors that can help you to design these services and these programs. That's something we do, but there's others out there, or you have some trusted people that you've written grants with or other thing. Because you need to be able to hit the ground running. Once the RFP comes, I think the deadlines, we saw that with New Jersey, right? It dropped the day after the funding announcement. And basically, they had 3 weeks to pull this together. And so line up your team and be prepared to take on a small scope of work. But you still don't know what it's going to be. And maybe the issue that what you're interested in the following year, we don't know yet. But go do a little bit prep work internally to select what are the things that you would love to see for your organization and really develop the mindset for your community. Right? What is the needs in your community that you can help facilitate and that bring you then also more financial sustainability? Because ultimately that's what it's about.
So that's a great point, Christian. I've seen in some of the articles that you've written a focus on sustainability, which of course is a cornerstone of the Rural Health Transformation Program. You mentioned that it requires a culture of innovation, integration, and performance. Can you expand a little bit on what that means and how rural provider organizations can achieve that?
Yeah, I mean, the first comment is really that I've been working in rural health since 2010, or working with a variety of different organizations. And what I've seen that these organizations, for the most part, really don't have the internal capabilities and capacity, or even the need, or haven't had the need to launch new services. They're good at running things. The better ones are good at implementing QA measures and continuous improvement and PDSA cycles to improve the quality metrics or the outcomes or whatever they want to improve. But very few organizations actually are good at launching something new. Now, they all had to launch something new, and for the most part, it always fails, or it doesn't go as smoothly as they would like to. And it's partially because there's not enough capacity there. There's not enough staff there to manage this. And then also running something is very different than launching something. It's a very different mindset. It's a different personality because it's mostly about change management versus operations is about optimization. So that's the first thing. And so when I talk about sustainability and innovation adoption, that's what I would really love to see. All right, if I could have my magic wand of what I want this RHTP funding to do, aside from the obvious improving access to care and health outcomes for rural residents, I want this funding to be leveraged so that all these organizations are really awesome at adopting innovation, that they can quickly scan, is this new AI feature, this new AI tool, or whatever we come up with in 3 years, is this good for our organization? Let's kick the tires on this in a few weeks. Let's pilot it. Let's try it out as a proof of concept on a small scale and then scale it, and really having that implementation science as part of the DNA. Because if we know one thing, the only constant is change, and we were going to get more and more and more digital health innovation that's going to be thrown at healthcare, and we as a rural healthcare ecosystem need to do that. And so that's on the innovation adoption, and then we can talk next year maybe about the kind of the sustainability and performance management.
Gotcha. And that's another thing that I had tweezed out of some of the things you've written and what you mentioned here is that organizations will frequently have barriers to innovation, and I think you touched a little bit on them here. I know that you have a process that you use in order to be able to identify and evaluate the organization and its barriers to innovation. Do you want to share a few words about that in terms of how an organization can go about, doing that assessment of themselves to figure out where they'll be best positioned to be successful?
Yeah, actually, a year ago, we developed an innovation adoption capability maturity assessment. It's on my website. in the innovation adoption section on the resources page. So the barriers to adoption break. The first one is resistance to change. That is the most predominant barrier to innovation adoption, because people, as a general rule, don't want to change, because change is risky, and you could embarrass yourself, you could hurt yourself, you could look stupid, and that's actually the one. Now in healthcare, especially, there's a lot of clinician hesitation with regards to embracing change, and that is for a good reason. I spent 12 years at the Mayo Clinic, and I learned about extraordinary care delivery, and you cannot just willy-nilly change out some medications, try a new procedure. I thought, oh, I modified the surgical tool. Let's try this out on the next patient, right? It's, I mean, you can do it on when you're in a car repair shop, but you cannot do that on human beings. And so it is in the DNA, and rightfully so, of the clinicians to resist change, because you want to have proven. But we're talking about tweaking the needle here on video visits or patient encounters, right? And there, the risk of something is not as high. And as I always like to say when we talk about video visits, right, a video visit is better than no visit at all. I mean, the risk of no visit is much more catastrophic than having a video visit, and so that's
100%.
the mindset change. So the biggest barrier to innovation adoption starts with resistance to change, and so that's why we have doubled down, or I've really become an expert in change management using two different frameworks. The one is the ADCOM model that I learned at the Mayo Clinic, and then the other one I gleaned from the book Switch by Chip and Dan Heath that was released 20 years ago. And those are really great insights into how to change human behavior in general. The other barriers to innovation adoption is technology still, right? So a lot of vendors are very narrow-minded as to their purview and what they see. They have the blinders on their solution, and they don't really understand how this needs to be integrated, not just from a technical API perspective of interoperability, but really from a perspective of how does it support or hinder the workflows. And I think that's the other barriers that healthcare is just still not systematized enough, right? You look at any other industry, and we have very systemized processes how to deliver care, but physicians and clinicians are, when the door closes on your PCP exam room, you can have 5 different experiences on the same day in the same clinic with 5 different clinicians. We're leaving it up to the individuals to do that. And I think that's still good, but that provides the challenge when we need to systematize. So I think workflow design, expertise, technical user experience, and then change management are the 3 biggest barriers that we need to be mindful at the beginning to overcome.
Yep, got it. So, Christian, when we talked about the need within this program to be able to demonstrate outcomes and such, that has a certain implication for how you think about and design the program up front to ensure that you are capturing the data that you'll need to be able to demonstrate that those outcomes. And I know that a lot of people will think about the program and the services that are going to be delivered up front, and sometimes will forget about the data that they've got to capture until later and say, oh, how do we go about, showing this and measuring that? Can you talk a little bit about methodologies that have been successful for some of the folks that you've helped in the past?
Yeah, it's a very simple process that we've inserted very early into the stream of designing the program. It's called we call it verification, right? It's service verification, program verification. And what it is you ask yourself kind of 3 different questions from 3 different angles. If anybody remembers the scorecard, right? The business scorecard from the late 1990s and 2000s, that's where I gleaned this concept from. And so transfer that over into care delivery optimization or telehealth services or digital enabled care. And the 3 questions you ask yourself is, or you're building a strategic case, a business case, and a clinical case. Meaning, you ask yourself, how will this particular service help us to achieve our strategy? And for RHTP, that then could include the state's RHTP strategy goals. It could include the particular RFP strategy goals, but then also your own organizational strategy. It's also we've designed this and integrated that from a change management perspective, because when people are aware of why this is important, then they have a higher desire in order to make the changes in the world. If they know, oh, when we do this, this helps our strategy and it helps our state, then it's more likely that they will engage. So that's the strategic case. The second one is the one that a lot of people think about, is the business case. What's the financial sustainability? And CMS is very clear on that, right? This is not funding to be used to pay for clinicians' time or to pay operational expenses. Right? This is a seed funding to create something that can then run by itself. And so really looking at how can we make this service financially sustainable, self-sustainable, so that it pays for itself or even provides a positive net operating margin. And then the third one, and that is actually the most important one, and that's the one that most people get, is clinical verification. Because the biggest obstacle to changing care delivery or optimizing care delivery is the clinicians, as we talked about. It's the change resistance. And so involving the clinicians from day one and helping them to understand and design with you how this will be clinically relevant and clinically appropriate and clinically a good way to do it, that is absolutely key. When we document it, it's less than a one-pager, right? So it's not an immense amount of effort. You call three 20-minute conversations with the right people, and you identify, do we have a strategic case here? Do we have a business case here? Do we have a clinical case here? And then you put that on the one-pager, and then in any presentation that you have, any meeting that you have, you remind yourself, this is why we're doing it. And it's a great tool that then we can also glean then the key performance indicators from the strategic, financial, and clinical objectives very easily. And that's how you start with the end in mind and really can then design the outcomes through those three lenses.
Yep. Yeah. Well, thank you, Christian. That makes a lot of sense. You've been doing good work with a number of different constituencies through RHTP. That includes states, that includes some of the hospitals and health systems within the states and such. Of the engagements that you've had, is there any nuggets that you can share that have worked really well for one of those constituencies that others might benefit from?
Wow, that is a very broad question. Thank you for that. I think staying with the RHTP, look at it through the lens of what I call and others call implementation science, right?
Yeah.
In order to pull this off and to pull this off well, and you're going to be held to account here, and money will be clawed back from some states, and there will be a lot of big outcry. You need to have a whole set of skills that you either need to recruit or train or that need to hire, need to outsource. And that's project management, right? These things need to be managed very tightly because we need to show results relatively quickly, as we started our conversation with. Secondly, an expert in clinical workflow design, really understanding how do you design workflows with their what we call happy day scenarios, or how things should be going, and the alternate scenarios when things go wrong. How do you prepare for that? How do you train people, and how do you train new people? How do you retrain? How do you hold people to account? So training expertise, and then ultimately a change management mindset. So having kind of this whole thinking through of how do you build the internal capabilities or hire it from the outside with technical assistants, consultants? How do you build the capability to launch new projects and have that in place? I think that's the one thing when we have been allowed by our clients
Yep.
to play full out in that. Not all teams, not all leaders are ready for it. Then they comment on, like, I have a testimony on our website where the CEO of an FQH says, this was amazing. They just not only helped us to launch telehealth, but we really learned of how we can approach kind of change efforts in a different way, right? And so we succeeded. So I was very proud of that. We achieved to transfer our knowledge and really empower the leadership team now going forward to manage their own change initiatives on their own as well.
Fantastic. So if I summarize real quickly, Christian, uh, align with your state's RHTP projects and see where the overlap is between your own strategic plans and those RHTP plans. Do your diligence with regard to evaluating your organization and where your barriers are to innovation. Design with the end in mind so that you capture the information that you're going to need to be able to demonstrate progress, and have a very focused change management plan, because the change management is every bit as important as the technology and the program that gets wrapped around it.
And win the hearts and minds of clinicians. Let that
Yes,
be your focus. Because then empowered and happy and satisfied and productive clinicians that are practicing on top of their license will provide really, really great services to their patients.
fantastic. Christian, thank you so much for sharing your expertise on today's show. And thank you to our listening audience. Join me, Mark Noble, right here on Healthcare Rewired for more insightful episodes focused on improving healthcare through digital health.
Thank you very much, Mark. It's been really fun. Appreciate it. And we'll put links to the articles and assessments in the show notes.
Fantastic. Thank you, Christian.
Thank you.